the anatomy of success, where MRI, how I think MRI has, as you just alluded to, it's kind of changed the whole equation, but it's really made things extremely exciting, and in ways I'll try to reflect. So here we have MRI on a young man who we can talk about in a minute, but this is a diffusion scan, and that's a very bad tumor in the anterior prostate that probably wasn't biopsied and would never have been known without MRI. And so, you know, that's all you need to know about MRI. You can find things you would never know were there, and you can intensify the dose. So, no disclosures, thanks to Jim Monty. That's a name some people may know here. On all my old papers, you know, trying to figure this stuff out was a long process, this anatomy, because what do we know as radiation oncologists? But I'd send these images to Jim, and he would tell me what, you know, and a lot of times it was kind of humorous. Well, I know what this looks like from inside a scope, but I've never seen it before. So in back and forth over years, and very helpful. But this is, again, we'll go back to modern success, means cure with quality of life. This is an image from the Lancet Oncology paper we did on functional anatomy. And it kind of, I think this picture is important because it sort of lays out what I think is the premier challenge in radiation oncology. I think it will be the premier challenge for 10 years because running through the prostate and adjacent to the prostate is all this critical quality of life impacting function. So I call it functional anatomy because it's very different. It's not like there's a tumor in the liver and you have expendable liver. You can just wipe out the liver, some portion of it. You don't have to worry about it. You cannot do that here. You've got moving parts, active parts, and they're synchronized and a lot's going on, but you can see some patients have those parts quite separable from the prostate, and we can kind of go through that, but the variations are extreme, and some patients really don't give us much of an option at all for sparing. There's no space between these critical structures, but we do need to deal with these variants. So I think we have to, this has kind of forced me in a subtle way to reimagine toxicity and quality of life. So I think first off, cure is quality of life. I said that, Sanda said that in his, that patients want to feel cured, but they don't want to just feel cured, they want to be cured. And I think I always would say the greatest toxicity you will ever cause is failure to cure an aggressive cancer. That is an outright failure. These patients are coming to you, they're handing their lives to you, and you better get rid of aggressive cancers, that small group that have to be eradicated. So I think MR can help us there. Brachy and MR are very natural together. But the other part is preserving function. So I'll just go to the next slide to kind of get what I mean. We're all worried about toxicity, severe, irreversible toxicity off to the far end here. So that's the bad stuff. That's the life-transforming rectal fistula, stricture, just disaster. There's no other name for it. And so we have that, and then the next level is severe but reversible, then minor medication reversible. But then on this side, loss of a positive isn't an unbearable toxicity, we would say, right? I mean, you lose your erections at 65 years old, and some guys would go so far as to say, oh, shucks, that's no big deal. But for some, that's a disaster. That's a big hit if that's an important part of your life. So instead of just saying, how can we avoid disaster, how can we actually get full preservation of function? Well, first, you have to map it out. You have to see how their functions are laid out, and you have to jump through some hoops to try to limit dose further. But the first progress we will have, and you can already see it in groups that have been starting to incorporate MRI, you're starting to see what I would call one and done severe complications, meaning someone has a stricture, like at Vancouver, they had 9% severe complications, but many of them were what I call one and done complications, meaning you have a stricture, someone dilates it or does some procedure to open it up, go on intermittent self-cath, and that's it. That is not a disastrous complication as I knew it early in my career. And so what does that due to? That somehow they limited dose, and they didn't do a long segment of something, and they didn't create a problem that's not reversible. Same thing here. We'd like to move from zero preservation to some modest preservation that a man can work with. Doing that is a separate matter, but so we'll go through. I'm going to talk about limiting toxicity, preserving function using MRI, and of course, improving cure, as I said, is job one. Limiting acute toxicity, though, is a very interesting challenge because the bladder neck is probably, so if you wanted to map it out very simply, bladder neck is acute toxicity and everything below the apex is chronic toxicity. And we could probably dramatically change acute toxicity, avoiding disasters, though, rectal fistula and strictures, and preserving sexual function. So where are we with this? Well, this was that gentleman I said. This is a 52-year-old man with a low risk, a favorable intermediate risk, a couple 3+4s. We were doing the MRI, and I told him when he got the MRI, I said, there's a good chance you can watch this. He was very much a big reader, and he understood that, and he, of course, had this high-grade lesion in the anterior apex. If you map it out, though, now this is where the advantage comes, because you can map out that tumor, and you can map it out in relationship to his external sphincter. So he had a very short external sphincter. He had this lesion bulging out and going down into the geodiaphragm a little bit. Surgeons will tell you they get beat at the apex a lot. There's a lot of positive margins at the apex because they're trying to cheat a little, trying to leave as much sphincter, and at the same time. So this, I did not have too much trouble talking surgeons out of not doing surgery on this guy. This is very helpful information, but it's all mapped out, it's there, and you can think about it in a very clear way. This is another patient who had intermediate risk cancer, real intermediate risk cancer, but a gigantic 85 cc gland and nothing at all up in that whole huge transition zone. Here's his sort of bladder neck. This is his proximal urethra, proximal 1 cm of the urethra. But again, we don't need to dose escalate the whole gland, thankfully. That's kind of going by the wayside. We need to pound this area. And if the peripheral zone is clear, we need to give some reasonable dose to eradicate. But we don't need to treat probably the base or a good part of the base at all, and that will modulate acute toxicity. And you don't want to be too cute with this, but I know in a patient like this, we could back off a lot. It's just hard to know how to do that, how to pull back from this mentality of hitting the whole gland, getting full dose of the whole gland, getting your D90 to X, Y, or Z. So a modest proposal for me on this whole tumor business is make sure the tumor area is well covered. I don't formally boost it because, some of these glands are small. You start adding extra seeds and the whole gland heats up. It's just all you want to do is make sure that region is not cold and back off on the free and clear zones. So then disaster avoidance, rectal fistula and stricture. I mean, I can't say how terrible these are, and they should be avoided, but they're still quite possible as you kind of play with fire. So let's look at this case. This is one that every brachytherapist knows. The LDR has been completed, and you look at the rectal row of seeds, and they're well within the prostate. You're feeling pretty good. You leave the OR, and the seeds are very close to the rectum. It's kind of maddening for anyone, but I think anyone who's done brachytherapy has seen this syndrome, what's going on. We figured this out with a long course, but this is the rectoanal flexure, that kind of where the rectum goes under the prostate. This is a geodiaphragm. This muscle is the rectourethralis. That was the big find here. When you put in a probe, you straighten out the rectum. You stretch this out. You can see this on ultrasound, on sagittal. If you put in the probe and then drop the probe down, you'll just see this sort of open up, as I call it. But you put your seeds in, they look beautiful. But maybe it's late in the case. You've got this sort of crenellated, edematous, not solid tissue that you put the seed in. So you get that nice picture, convince yourself those seeds are in beautiful position, and lo and behold, you pull out the probe, and there they are. They sort of recoil, the rectum recoils, and you recoil in horror as well. But what can we do? So now if we look at the MRI, I always say this muscle has been hiding in plain sight. So it's a thickened area in the rectal wall. It looks like a bad wig. And then the muscle extends up right into the the GU diaphragm here. So you've got the GU diaphragm levels clearly. Here's the levator inbowing, starting to inbow here. It's concave, starting to be convex. Here it's convex, very clean. You're in the GU diaphragm here. And then below that, when this, I call it the gold medal pose, like when the GU diaphragm, when the sphincter goes out in front of the levators, this is like the arms held up, someone Olympic holding up his trophy. Well, you're way, way down in the GU diaphragm. Easy to know you're not prostate anymore. And but there's that muscle. So on sagittal ultrasound, this is what it would look like. You've got the prostate, you've got the penile bulb, you've got the GU diaphragm between, and this is a sort of Bermuda triangle. I think Fred Lee, the ultrasonographer from 30 years ago, called this the quadrangle, but it's a potential space, and what you want to do is avoid this first and foremost. You do not want to have seeds get pulled down into this triangle, and preferably you will actually place that rectal row immediately adjacent, superior to ideal. You can pretty much count on that whole thing collapsing and smashing together, and you can pretty much count on that row of seeds being farther away from the rectum, but you'll have full dose coverage, so that's really kind of the ideal. But again, we're all playing battleship, right? You know, we got this row, we want to hit it, we see the needle hit right in that row, and you actually want it to go forward to that. And a lot of people do different things. Juanita actually puts the needles, if you've got bendable needles, you can put it one row up and then bend it down to the base. That's a great way, probably the best way you can avoid this disaster. But it's a trick, but I think to know the mechanism of that is kind of amazing, helpful. We can figure out the solution. And so this, though, is another way of trying to take rectum dose to another extreme. So this is a good, what I would call a good RTOG plan. The 50% line bisects the rectum, hits all the constraints, but you have to say, you know, people always said these algorithms are stupid, right? They're just doing the math. You give them a big rectum, it's going to say, I got a lot of room to spread some extra dose around. So this is what most of the plans look like. We worked out, I'm thinking brachy, we need these gradients, rapid, high to low, and we did this gradient optimization planning where we can go from 86 gray or 90 gray down to 50 gray in less than a centimeter. So that's a huge difference in planning, and you can force that. So very impressive. Maybe it's too good, meaning with motion and so forth, is this too good? But it's incredible what the capacity is if you sort of work the system. What's an exciting prospect, though, is combining this with that spacer, you know, the company out here where you put a space between the prostate and rectum. If you took gradient optimization and spacer, you would have what I would call pure preservation of function. You would have zero rectal dose, and very achievable. I mean, we're halfway there. Interestingly, our rectal toxicity with our combination patients is statistically significant less than our beam patients that go to 80 gray external beam. Our combination patients, because of this. So again, DVHs are different. It's impressive. So if we then look to the stricture area and the external sphincter, this is quite possibly the most famous picture in functional anatomy. This is by Coakley in the Journal of Urology, and he looked at a lot of patients going to surgery and found that if the external sphincter was 1 centimeter or more, they had very low risk of incontinence after surgery. So what a gift, right? Guys come in and that's the one thing, I can lose my erections, but please do not let me be dripping in my pants forever. And if you can look at a guy and say, we can predict that, it's phenomenal. But what's so interesting is no mention in that paper at all that sphincter goes right inside the prostate. It goes way inside the prostate. And so about 12 years ago, we put this in Prostadoodle. I had no idea this was a unique finding or an important finding. We just said, note the external sphincter goes into the prostate to the verumontanum. But then when we went to write up the paper, I said, I better check. So this was not Jim Monty I checked with. And you can tell it wasn't Jim Monty because he said, Bill, the reason we call it the external sphincter is because it's external to the prostate. He didn't write "you frickin' idiot," but, it was right there to be so. But he was wrong. And in the last 5 years, there's been several papers, really great urology papers, telling you that this is what's happening. Some beautiful, it's not just smooth muscle, it's smooth and skeletal muscle, it's wide variations in this, and it's a substantial part of the apex when you implant. I mean, it's a big diameter, and you see this on MRI. But it varies. So here you have someone with a very long sphincter outside the prostate, a tiny bit inside. Here you have someone almost 50-50. Well, why is that important? As you get to the apex, you're in pure peripheral zone. That's an area at risk. So here you have the highest area for tumor risk, peripheral zone tissue, and you've got a sphincter, not a tissue, but a moving part going up into the prostate there. So knowing that is a huge value. But just to give you an idea of the extreme variation in external sphincter length, this is this is from the functional anatomy paper, but it's, you've got a guy with almost 3 centimeters here, and you've got someone with less than a half centimeter here. And I'm going to talk about this a little with the post-prostatectomy too, because this makes a huge difference. But just to refresh our memories, anybody who's been around as long as I have remembers how we used to set the bottom border, right? We used to set the bony bottom border, and this is where we would be treating if we kind of put it at the bottom of the ischium the way we used to do 30 years ago. It's painful to think about this. So we would pour dose all the way through the penile bulb, all the way through this, all the way down. All of this was treated. So if you're planning with MRI, you'd be up here. If you went a little ways into the GU diaphragm and overestimate it here, most people contouring on CT, look, I've stopped above the penile bulb. I didn't do what the cardinal sin, which is contouring all the way to the penile bulb. But just knowing, we're putting inches of tissue to full dose without knowing it. We had no idea what a GU diaphragm was. So very valuable in quality of life and avoidance of disasters. So stricture avoidance is just limit the length of high dose, right? Even though you have a CM into the prostate, you can limit the high dose to that. You just don't want to drag dose down below into the GU diaphragm. Know the apex anatomy. And then vessel sparing, this is another where we mapped out the erector set of the internal pudendal artery, the corpus cavernosum, and especially we mapped the apex very carefully. So all these tissues that appear to be sensitive to radiation, unlike the nerve sparing. And we reported this is in European Journal of Urology, just came out last month. I think it's only online now, but 90% self-report their ability to be sexually active at 5 years. Most interestingly, there was no difference for the combination. So even though these patients, 2/3 of the patients got full bore seeds plus beam, most of them were intermediate and high risk, they had sexual preservation the same as the beam. And interestingly also, because they got combination, they only got 6 months of hormones. So sexual function took a dip for hormones at 2 years, but by 5 years it matched. So all of this stuff is dose, right? You put dose in and you're going to see toxicity. If you don't put dose where you don't need to, you can completely change the cure and quality of life. So that's what the erection tissues look like, and this is a case that's a little tougher here. They're pretty close to the prostate. Here it's so far away, you would have a hard time getting any meaningful dose down into those tissues. Neurovascular bundle, though, is going to turn out to be a key piece because, again, this is the neurovascular bundle we all grew up on. There are studies out there on CT where they just draw a circle in the posterior lateral and say that's the neurovascular bundle, but this is only present in about 55% of cases. In 30 to 35% of cases, there's a plexus that runs along the wall, and surgeons know about this. The veil of Aphrodite technique is just sort of onion peel that and leave this plexus there. But I think it's something we can exploit as well. Bladder neck, I just want to go through how spectacular the bladder neck anatomy is depicted. And as you age, the transition zone hypertrophies and sort of pushes up and obliterates the bladder neck. And so if we look at what we would call a level 1, you have a completely intact bladder neck. Level 2, you sort of have effacement, kind of crowding. And then level 3, it's actually going into the lumen of the bladder. Finally, you get this median lobe, where it's asymmetric, where one part comes up and overarches the other. Again, you can see this so clearly. It's so helpful to know that's there as an avoidance structure or avoid brachy. But also, if a patient really wants brachy, you can actually just lop the lobe off if you can find a surgeon who will do a limited TUR, and that solves the whole problem. But also, you can get surgeons to do what's called a golf tee TUR. And again, I have one in Michigan who will do this, where they do, this is sort of the golf tee TUR. They don't take out all this tissue. They just open up the bladder neck very discreetly, and that can solve the problem and allow you to do things. MRI, though, can also show if you have a TUR 12 years ago and you're thinking, should we implant this, you can get a tremendous amount of information from an MRI. You can see all this residual tissue. They have no problem doing an implant in this. So this is kind of a Sesame Street slide, and I just put it up here to show the challenges, that if we kind of map out the zones and the challenges within the prostate, I think all of us are going to be mapping this out and thinking about this in the years to come. And what this really means is you have red areas within tumor disaster potential. That would be the apex sphincter. You have adjacent to tumor disaster potential. That would usually be the stricture or rectal fistula. Within prostate complication potential, adjacent to prostate complication potential, and separable with complication potential. So those are all kind of grades of risk zones, and I think that's how we're going to be planning. We're going to be really looking carefully at the sort of regional within the prostate, the regional challenge we face when tumor is here versus here versus here. So cure is the ultimate toxicity to avoid. Rectal fistulas, I think whenever you can understand the mechanism of something, you got a shot at really solving it. Strictures, again, I call that ground zero because you've got tumor and a functioning structure right there. And finally, bladder neck, I think acute toxicity avoidance is going to be very, very possible in my limited experience so far. I think that's going to be a very promising area. Thank you.